This Week in Virology, the podcast about viruses, the kind that make you sick. From Microbe TV, this is TWiV, This Week in Virology, episode 1190, recorded on the 6th of February, 2025. I'm Vincent Racaniello. You're listening to the podcast all about viruses. Joining me today from New York, Daniel Griffin.
Hello, everyone.
With the black and white tie. What's that?
This is the coronavirus bow tie. If people look at that closely, you can see the spikes sticking out like a corona. So,
right.
So the first thing I'm going to say before even my quotation is, hello, everyone. The MMWR came out again today, February 6th. We have an MMWR. Apparently no mention of bird flu. So sort of an interesting, I was sort of surprised.
So here's my question, Daniel.
Yes, your question.
How do we know that this is what was intended to be published or if it's censored in any way? We have no idea.
We actually, this was censored. The reason we know that is they were about to publish 3 reports on bird flu, and they're not here. So,
What the hell are they censoring that for?
Vincent, you're a grumpy old man.
Yeah, I am.
All right. So let's jump in with our quotation. If you do not change direction, you might end up where you are heading. That's from Lao Tzu. You know what I'm going to say, Vincent? I'm going to be the less grumpy, not as old man. We were not headed in a good direction, right? I mean, we over the last 4 years have seen vaccination rates dropping across the country. We've seen the anti-science and anti-vaccine movement growing. We were not headed in a good direction. So I actually think it's time to change direction because we have not been heading in a good direction. Maybe everyone's going to wake up and realize, quadrupling in the number of measles cases last year. We had, all these kids ending up in the hospital. We'll talk what's going on with flu in this country. All right, but let's start with TB, right? The Kansas Department of Health and Environment, with support by the CDC, right? Local health departments, they've been responding to an outbreak of tuberculosis in Kansas City, in the metro area since about a year ago, since January of 2024. It's been going on for the last year. And as of the end of January, there were 67 confirmed cases of active tuberculosis, including 60 in the Wyandotte County, 7 in Johnson County. Of these individuals, 35 have completed treatment, are considered cured, 30 are currently under treatment. So most are no longer considered infectious. And there have been 2 deaths. And, people ask a little bit of questions about this. Is in a metro area. Some rumors that it spread to Ohio. I believe those are unsubstantiated, by the way. So,
Dixon, Daniel, do you know how many cases of global TB there are typically?
So millions.
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 And in like a country like India in particular, a lot of TB. So, this is not a big deal, but it is because we don't have any usually. But people need to realize that this is a problem elsewhere. And you know what, Daniel? No one is safe until everyone is safe.
Imagine that. Parasites know no borders. In actually the last year, so 2024, tuberculosis, as far as deaths from a single pathogen, it's actually risen now. It's the top of the list. So we've got tuberculosis. We've got malaria. We've got HIV. COVID's actually, coming down. It's being, So let's talk about some other viruses, the kind that make you sick. Marburg. So we have an update from MSF. It's a little old. I wanted a little more up to date, so I put on my glasses here. Actually, I was lecturing to Médecins Sans Frontières, Doctors Without Borders, this morning. And as of January 28th, the Ministry of Health reported 2 confirmed cases, 2 deaths, 8 additional probable cases. There are also 64 suspected cases, 281 contacts being monitored. despite the president's order regarding WHO, the CDC has been cleared to speak one-on-one with WHO counterparts related to response activities in Uganda. A CDC spokesman said in a statement. And while officials secured a waiver on Saturday from the State Department to free up some funds for the response, this is actually what I'm also hearing on the ground. Many folks on the ground, they're actually reluctant to accept money because of all the turmoil in Washington. So they don't want to do something and then find out, we really weren't supposed to do that. So they're waiting for like specific letters that say what you're doing is okay.
Daniel, I think this change of administration was a big mistake.
I think we know how you voted, Vincent. All right, Ebola. So Tuesday, February 4th, so it's just a couple days before we're recording, we heard that a second person, the wife of the index patient, tested positive for Ebola. And then as of February 5th, there are now 6 confirmed and another 6 suspected cases of Ebola in Uganda. And a couple things I'm going to talk about. So one, a little background, but also a little bit share from some of my friends on the ground. So the important is, it's Ebola. We know about Ebola. We had that big West African Ebola. Why don't we just start vaccinating? This is not the same Zaire Ebola that they had in West Africa. This is Sudan Ebola virus in Uganda. And the WHO is jumping in. They've allocated $1 million from this emergency fund that they have. There are no licensed vaccines for Sudan Ebola. So what they're actually going to be doing is they're starting a vaccination study. There's already a couple thousand vaccine doses already there on the ground. We're going to see if this new vaccine works. But the case fatality rates from the Sudan virus disease have varied from 41 up to 100%. What you'll usually see is really high mortality initially. Once they know what it is and you get better supportive care, you can actually push that case fatality rate down. But a little bit of what I've sort of heard here on the ground. So that original individual who unfortunately has died, this was a male nurse. The male nurse was ill, went to several different medical facilities seeking care. And so imagine this, here you are, sub-Saharan Africa, you're in Uganda, you've got a fever, you feel crummy, tests are negative for everything, negative for malaria, not sure what's going on, goes to a bunch of different hospitals, including the local regional hospital near our clinic in Uganda, and eventually ends up dying. So they've gone ahead and they've set up these potential Ebola treatment centers, and I'll say at the Mbale Regional Hospital. But no one's showing up for work. And why is that, Vincent? It's a couple things. There's an adequate protective gear, right? So, hey, come to work. You might end up taking care of an Ebola case, but you're not going to end up with appropriate protective equipment. Also, we're sort of, are we better prepared than we were before COVID? Well, with COVID, they said, don't worry, we know this is hazardous. We'll pay you like hazard pay. Those payments never went out. So people are saying, why am I going to come to work? I'm not going to have appropriate protective gear. And even if you say that you're going to give me some kind of bonus to make it worth my while, I may never see that money. So not great what I'm hearing from folks on the ground. All right. So I am less optimistic here than I was with regard to Marburg. All right, bird flu. We've got a couple fun articles, but I want to be critical about these. So the first article is by our buddy, your buddy, Carl Zimmer. Could the bird flu become airborne? And so Carl Zimmer published this in the New York Times, and I actually think people should read this, so I'll leave in a link. There are a few high points that are worth discussing. And the first I'm going to say, it's really important. It's this crazy airborne language versus the new, and what I'm going to say, much clearer terminology, maybe, spread through airborne viral particles or AVPs, right? So these infectious respiratory particles. And so I thought about maybe a few ways that we might rephrase the title. I couldn't come up with anything that was quite as catchy. Let me try these out. Could avian influenza evolve to become efficiently transmitted person to person through airborne viral particles? And I just want to spend just a little time because this article actually sort of beats up on the WHO. I'm not sure we need to do that. But just to kind of refresh, right? When we went into COVID, we were using this distinction between airborne and contact terminology that it was 100 years old, created nothing but confusion. People ended up with different camps. And so I just want to sort of lay this out in what I think are simple, understandable things. Like, let's think about this, right? I've got dogs. One of them was just nuzzling me, even though I fed them dinner already. They want more because they're always hungry, something about a ghrelin deficiency. But when my dog is out in the yard or maybe going for a walk and I want to clean up after my dog, right? I mean, I am well aware that I want to protect myself so that I end up touching the poo. But I don't have to wear an N95. I'm not going to get sick. It's not going to be floating around. Now, contrast that to that's a contact transmission scenario. Many of our respiratory viral pathogens, like the circulating human influenza or SARS-CoV-2, the virus that causes COVID, these are actually things that you can breathe in. You don't have to actually touch the infected person. And then there is this sort of this variation between if I'm really close to that person, I'm at higher risk than if I'm farther away, but in a poorly ventilated area. So I wanted to bring up those famous experiments, Vincent. You're going to get us in trouble here.
But before you go on,
yes,
there was no confusion at the beginning of COVID. It was clearly transmitted through respiratory droplets. That's how you get rapid transmission, community transmission. Anybody who was confused was not paying attention. And as for Carl Zimmer, this same article was published in 2015 when we last visited. And there's no answer, Carl. Maybe or maybe not. So what's the point?
So he just took the same article and just refreshed it, put it back out
Well,
there?
the 2015 was an op-ed by Michael Osterholm. Okay, so it's the same thing. Hey, how many years later is that?
Yeah.
And it still has not gone airborne.
Well, I think that's the interesting thing, right? And so, let's spend a little time. This is worth it. So 100 years ago, there was this whole thing. It's that, you don't get sick from just breathing in, quote unquote, the miasma, the bad air from, miles or distances away from the swamp, et cetera. You actually have to somehow get infected. It's germ theory. And so someone's got the flu, they've got SARS-CoV-2, you're within 3 to 5 feet, 3 to 6 feet, they're coughing, you're breathing that in. That's very high risk exposure. Now, you're in a suburban home, you're 12, 20 feet away. You're really not far enough away if there isn't good air exchanges. You get in the subway with 30 other people. You like measles, tuberculosis. There's a gradation. There's no wall here at 6 feet where suddenly you're safe. All right. So, but let's talk about the famous and notorious ferret experiments. Remember the gain of function and loss of function?
Of course. Of course.
And so here we learn that H5N1, right? In general, if you just leave it in its current state, the ferrets actually have to touch noses. They have to actually have contact for it to transmit. But a few mutations, and then they can actually be in cages separated by a little bit of a distance. And now the virus can go from one ferret to the next across this gap. And so there's a gain of function. It can cross the gap, but there's also a loss of function. Now the next ferret gets infected, but it just gets a mild case of sniffles, doesn't actually get really sick, right?
Which everyone ignored. Okay. Oh my God, it's transmitting through the air among ferrets. Yeah, but it doesn't do anything.
Yeah, now it's been basically, So we're going to kind of circle back to this because this is going to come up in a minute. So right now, we're seeing that if people are going to get the bad genotype D, the directly from ducks, the deadly H5N1, you really need to have some pretty direct poultry exposure. Once a person gets it, we're not seeing transmission from that person to the next person. Now we have that dairy form of H5N1. That's the genotype B for benign or bovine. And in general, for people, this is pretty mild. Now, in this article, I love this closing quotation from Dr. Lakdawala, a virologist down at Emory. Right now, we are seeing more and more H5N1 in ducks, hens, turkeys, different mammals, and humans have a higher chance of exposure. We don't know if there will be a change that makes H5N1 able to spread via the respiratory route. I think it's really via the respiratory route from one infected person to another. We don't know if acquiring that ability will be associated with a gain in virulence, no change, or will be associated with a drop in virulence. What's shocking to me is that we're letting nature do this experiment. I was going to say letting nature do this gain of function, loss of function experiment.
Look, this is silly. You cannot stop nature from doing its thing, okay? What you can do is try and do it yourself. Dr. Lakdawala, we tried to do this in 2015, and things really blew up. That's where all the anti-gain of function people came out of the woodwork and say, we can't let virologists do these experiments. So Dr. Lakdawala, you go talk to them and convince them that this should be done, because it's not happening.
All right, so a couple more updates. Avian flu strikes more Nevada dairy herds, leading to starling removal. So we heard from the U.S. Department of Agriculture, more H5N1 avian flu detections in Nevada dairy herds. This affects the state's first since December, along with several more detections in U.S. poultry flocks. Federal and state groups will also be removing non-native European starling populations. I thought this is sort of interesting. They want to get rid of those starlings because they're concerned that they might be spreading disease. North Dakota wildlife officials are monitoring a Canada goose die-off along the Missouri River. We might also be having similar issues more close by to where we're recording up in Massachusetts. And tests on carcasses have shown highly pathogenic avian flu as likely cause. Also, more H5N1 detections in at least 7 states, including commercial farms in Missouri. The turkeys and the broilers, Ohio turkeys and layers, and more detections in backyard birds were reported in Maryland, Virginia, Florida, California, and Nebraska. And only a couple last things here in the bird flu. Are eggs safe to eat as bird flu spreads? Now, this is kind of interesting, right? I've always bemoaned this. Like you go to other parts of the world and you get your eggs, and the eggs can sit out on your counter for weeks. And here in the U.S., like we sanitize them, we rub them clean. I don't know, maybe in this situation, there's a certain benefit there. But here's kind of the latest thing. So we just learned that the dairy form of H5N1, right, is genotype B for benign or bovine, and for people it's pretty mild, remember, and genotype D for directly from ducks or deadly, that's the bad one. Well, we just found out this week that the USDA confirmed by whole genome sequence the first detection of H5N1 genotype D in dairy cattle. So the new spillover was detected in an investigation that followed confirmation of H5N1 in milk sampling from Nevada dairy cows. We actually don't know if this particular spillover into dairy cows is going to, should this end up in human beings, be deadly or benign.
Well, we don't even know if it's replicating. All they have is a detection.
Yep.
Okay.
Yep.
So we have to wait and see.
Imagine, we don't like to wait, Vincent.
Okay.
Okay. All right, so an update. So I know the MMWR doesn't mention bird flu, but stuff's going on. Actually, my wife texted me when I was at work today that she was going to go to the store and buy eggs for dinner. And I was like, dear, am I made of money?
What are they costing these days?
It's like $1 an egg. It's like $12 for a dozen. They have become so valuable that instead of robbing banks, people are now holding up egg trucks. It was just in Pennsylvania, 100,000 eggs were like stolen. So.
I walked into the incubator yesterday. There was a restaurant on the corner. They were just getting food delivered, and there were 2 huge cases of eggs. And I thought, why isn't somebody taking those?
They're going to need like armed guards. They're going to start driving around, Wells Fargo trucks or something. Okay, so polio. Let's get into polio. So the article, Global Impact of Mass Vaccination Campaigns on Circulating Type 2 Vaccine-Derived Poliovirus Outbreaks, an Interrupted Time Series Analysis published in JID. And I'm going to be a little critical of this paper. Maybe Vincent will be a little critical as well, but particularly introduction. So we'll start out, who are the authors? Do you know any of these authors, Vincent?
Yeah, I know some of them, yeah.
So we've got a number of authors from the School of Public Health, Medical Research Council Center for Global Infectious Disease Analysis, Imperial College London. Also some authors from the Bill and Melinda Gates Foundation, Polio Team Seattle, Washington. So many multi-letter acronyms here, so I will make a point of always spelling them out. So in the intro, they say a number of things, including type 2 OPV, so OPV2, type 2 oral polio virus vaccine, was withdrawn from routine immunization in 2016 as wild type 2 polio virus had been eradicated, and the majority of circulating vaccine-derived polio virus detected was type 2. And that's this little c for circulating, VD, vaccine-derived polio virus, little s. Unfortunately, as we read, post-withdrawal outbreaks of circulating vaccine-derived polio virus 2 led to responses using monovalent OPV2, leading to over 70 new emergences of circulating VDPV2 and cycles of outbreak and response. Between 1 May 2016 and 30 December 2023, 3,253 circulating vaccine-derived poliovirus 2 cases were reported. Then along comes novel type 2, OPV, which is suggested to have greater stability, and the hope is this will reduce the likelihood of future vaccine-derived poliovirus outbreaks. So here they ask whether there is evidence for this change working. All right, so we're going to do some science, and here they compared the impact of the novel OPV2 to the monovalent OPV2 supplemental immunization activities, SIAs, on the circulating vaccine-derived poliovirus 2 poliomyelitis incidence and prevalence in environmental surveillance across 37 countries, directly comparing the supplemental immunization activities, SIAs, in 13 countries where both vaccines were used. So to be clear as mud, are they looking at poliomyelitis, the disease, or environmental detection of poliovirus? Generally, they're looking for disease, and they're not really, and if you look through, you're not going to see a lot of wastewater sampling or anything like that. What did they find? They did not find any statistically significant differences between the novel OPV2 and the old-fashioned OPV2, except in one place in the DRC. Vincent, thoughts? What's going on here?
Yeah, so this NOPV2, which was engineered as to maybe be more stable in terms of reversion to neurovirulence, is no different from OPV2. It is, so the question really is, was its development in advance? Its effectiveness is the same as monovalent OPV2. There's a slight reduction in vaccine-associated paralytic polio. It is not the answer to the problem. It's not the answer to all these type 2 vaccine-derived cases. I think we need to move on to IPV.
Yeah, I think so too. And I've been talking to some folks recently, and, I'm always trying to find out, is there a silver lining to what's going on in the world? Because, boy, there's a lot of things that are troubling going on right now. Us sort of pulling back from the WHO. And if we're going to rejoin the WHO, maybe we rejoin and we say, hey, as one of our conditions, let's rethink what's going on with polio.
Well, we definitely need to have a committee meet and discuss this, because things have to change. You can't just keep putting an OPV2 into children and they get paralyzed and you get more circulating virus. Is not the solution.
Yeah. I mean, you can't have 3,000 children paralyzed from a vaccine, right?
Yeah. That are 3,000 human-made cases of polio.
Yeah. Not okay. Not okay. All right. So influenza. Oh my gosh, there's so much influenza. We are really at high activity. And guess what? We have updated CDC flu map from January 25th. So I'm excited. Well, what I wasn't excited about was to just see how many areas are not only high, but very high. Flu is really at high level. We're seeing lots of cases in the hospital. And unfortunately, we're actually seeing more flu deaths. And flu deaths in children, we were up to 16 by the end of January. We've talked before, about half of these kids that end up dying in the flu were completely healthy before this hit. So this is not like kids that were going to die anyway or any horrible thing that people try to suggest. But a couple flu articles, the article Co-infection of SARS-CoV-2 and Influenza AB among patients with COVID-19, a systematic review and meta-analysis published in BMC Infectious Diseases. So these are the results of a meta-analysis that included 38 primary studies, really asking the question, like, can you get two things at the same time? If you've got COVID, could you also have the flu? And I remember it was sort of painful back in 2020. Like we turned all our machines. We were only doing COVID tests. We stopped testing for influenza. And if you don't test for influenza, you can't get a positive test. So everyone was basically saying there were no co-infections. Well, if you test for both, as you see in this meta-analysis, about 14% of the folks with COVID also have influenza. There's forest plots, so you can see all the studies. Basically, if you've got COVID and influenza are circulating at the same time, you're going to see lots of co-infections. And we have treatment for influenza and we have treatment for COVID. So it's actually helpful to test for both.
Can you use both Tamiflu and Paxlovid at the same time?
You can. You can even use Xofluza at the same time as Paxlovid. Yeah.
Cool.
All right. And yeah, speaking of oseltamivir, does it work? Is there a benefit here? So we have the article, oseltamivir reduces 30-day mortality in older adults with influenza, a pooled analysis from the 2012-2019 Serious Outcomes Surveillance, SOS network of the Canadian Immunization Research Network. CERN, published in Open Forum Infectious Disease. Here, among the 8,135 influenza patients studied, 2,126 did not receive antiviral therapy. 6,009 were treated with oseltamivir. Oseltamivir recipients had an 18% lower risk of 30-day mortality. The benefit was significant for influenza A, but not for B. And oseltamivir remained effective when initiated after 48 hours. Influenza vaccination did not mediate the effectiveness. So, even in folks that are vaccinated, the Tamiflu can have a mortality benefit, at least in this study.
If I remember correctly, Daniel, the Paxlovid data for COVID, it's like 80 to 90% lower risk. So why is this only 18%?
It's not that great a drug. I think that's the problem. Yeah.
And do we have similar studies for Xofluza? Probably not, because it's not enough use, right?
We need better studies with Xofluza. There's a lot of barriers there that we've talked about. It may be a better drug, and it would be nice to see more data. Particularly, I would love to see data in hospitalized patients. All right. RSV, still very high. It's really, number one right now. We're seeing lots of flu. We're seeing COVID, we're seeing RSV, and the RSV activity really similar, sort of widespread. Lots of parts of the country are still at pretty high levels.
Daniel, I wear a mask all the time now during this respiratory season. My glasses are all fogged up. I'm afraid I'm going to roll down the stairs one of these days, and it's going to be worse.
I've been in and out of the city quite a bit, and oh my gosh, to get on a subway car without wearing a mask, you do your equation, and just you're just really at high risk.
No, but the fogging is a real problem.
Yeah, I don't have to wear glasses for distance, so only for reading. So I'm a little lucky. Some people do stuff where they try to get a good seal, maybe put a little bit of tape on the nose, try to keep the glasses from. The other is you wash your glasses with the dishwashing soap, and then you don't aggressively rinse them, and that creates a little bit of a film that can help with the fogging.
I should try that.
Okay, SARS-CoV-2 levels remain high. And this, I was discussing this at work today. In certain areas, like let's take New York, New Jersey, Pennsylvania, right in our immediate area, 2 to 4% of the deaths are due to COVID. So that's about 1 in every 30 deaths that occur. they're due to COVID. So COVID is still a pretty significant cause of death. We estimate it's about 1,000 people a week. Everyone says, oh, it's not a big deal. What's a big deal for those 1,000 people that die each week? It's a big deal for those people who care about those 1,000 people that die each week. And wastewater, we got updated wastewater, Vincent. And unfortunately, what did we see? Levels started to go down, and now we're actually seeing that as the end of last month, we're actually seeing an uptick again. So, all right. I was looking through NIH and IDSA guidelines, and basically the NIH guidelines are just a static PDF that you can look at. We still have our IDSA, ID Society of American guidelines. And if you look at the guidelines, right, number one, acute first week, we see that 90% reduction in progression, whether you're vaccinated or not with Paxlovid. So you take that baseline risk. And updated Paxlovid is now available in a third packaging configuration. So relatively normal renal function. You've got your standard. We've got our moderate renal impairment. So that's a GFR of 30 to 60. And now we have a new packaging for people with a renal function, a GFR, glomerular filtration rate of less than 30. You can even use this in folks on dialysis. And on dialysis days, the Paxlovid is just given after dialysis. So there's a loading dose, and then there's a daily dose over days 2 through 5. So now bad kidney function is not going to keep you from being able to help your patients. And as we've talked about several times, patients with kidney issues, they're actually at a higher risk. So remdesivir for folks with drug-drug interactions, it's challenging because of the IV therapy. Molnupiravir, convalescent plasma, and remember, you're infectious. Second, early inflammatory phase, right? This is often that bad week. You start to feel better, and then the inflammation kicks in. Steroids in some individuals, anticoagulation, pulmonary support, remdesivir if we're still in the first 10 days, in some cases, immune modulation. All right, the late phase long COVID. I'll leave in a few links here to treatment centers and the long COVID, the Answer website. Also the long COVID paper that was published a little bit back. But there are a couple papers, just two, that I just want to mention here and leave the links to. First, to start with the kids, the article Long COVID Prevalence and Associated Activity Limitation in U.S. Children, published in JAMA Pediatrics. They use data from the 2023 National Health Interview Survey, nationally representative cross-sectional household survey of civilian, non-institutionalized U.S. populations. This is looking at children aged 0 to 17, randomly selected. They actually have a pretty good response rate. 44.9% of people respond. And overall in 2023, 1.4% of children surveyed had experienced long COVID, and about 0.5% were currently experiencing long COVID. So that's pretty high numbers there. The prevalence of long COVID symptoms was actually even a little bit higher. When you look at those teenagers, 12 to 17, it was 2.3%. So what is that? About 1 in every 40 or 50 teenagers were actually having long COVID symptoms.
So this is a good reason why kids should be vaccinated.
It's really tough, right? Because there's all this misinformation, I'm going to say, out there. Oh, I never give why would I do that? Long COVID, it's not an issue for kids. It is an issue for kids. We had over 1,000 kids die of COVID. Here we're seeing all this long COVID. COVID is a thing for kids. All right, the article, Plasma Proteomic Evidence for Increased Beta Amyloid Pathology After SARS-CoV-2 Infection, published in Nature Medicine. So, oh my gosh, can you get dementia from SARS-CoV-2? So we know that some other viral infections have been associated with increased risk of dementia. So here is SARS-CoV-2 doing this. So this group measured plasma biomarkers linked to Alzheimer's disease. And yeah, they actually found that some of the plasma biomarker changes were greater in patients with COVID-19, particularly those that had been hospitalized. And so they're actually suggesting that maybe SARS-CoV-2 infection might lead to greater brain amyloid pathology in older adults.
Maybe the SARS-CoV-2 infection is reactivating a herpes virus, which is the actual cause of the dementia.
That's actually, so I've been listening to some of the other micro TV podcasts, watching some of them. And yeah, there's this really interesting concern that maybe reactivation of some of these latent viruses actually, are leading to these inflammatory changes. And maybe it's the immune response to try to get those in check that's actually leading to some of this pathology.
I mean, I don't see any good evidence that SARS-CoV-2 is reproducing in the brain, yet there is evidence for herpes simplex. So that's clearly inducing phosphorylated tau and so forth. And we know that SARS-CoV-2 can reactivate latent herpes viruses. So maybe, I think that's probably the connection, not SARS-CoV-2 replication in the brain.
I mean, I think, to be honest, that's what the evidence supports. I know people are pretty emotional about this, but yeah, that's currently what the evidence is supporting. And if that's the case, then hopefully we can start thinking of ways to intervene. All right. No one is safe until everyone is safe. We are right now in our Floating Doctors fundraiser, February, March, and April. We're going to double your donations up to a potential maximum of $20,000. So this is where I want everyone to pause. Go to parasiteswithoutborders.com, click on the donate button. We reached our goal with Microbe TV. The check is in the mail. So thank you, everyone. But just an update. So the Floating Doctors, they're down in Panama. So I got an update from Panama today. And this is what we hear. Our vet team came back from a multi-day clinic recently saying that the financial development in one of the communities tied up in pigs and cows is being threatened by an uptick in screwworm. Remember we talked about screwworm? These maggots just burrow in and just horrible. And so they're actually concerned, because the pigs and cows are part of how they provide for themselves. They're living on the edge, so financially catastrophic to be losing those pigs and cows. And also with the rainy season, we heard from the vet, the intestinal parasites are having a rager, so a lot of issues there. And last week, the medical team did their first multi-day clinic in a new community about 3 hours away by boat, up one of the rivers. It's just past Playa Verde, which is where I was when I was last down there with my daughter. And we get a nice summary that they were welcomed warmly with this nice sign in Neve and English and Spanish welcoming them. A big issue they were seeing was dehydration. They're seeing malnourishment. They're seeing some stunting, some cases of genetic syndromes. And really, they basically were saying malnourishment was a really significant issue. There was a 3.5-year-old patient weighing only 7 kilograms. And one of the big issues is they're worried about the supply of RUTF. What is RUTF? This is ready-to-use therapeutic food. It's this paste made from peanuts, milk powder, oil, sugar, vitamins, and minerals. So not only all these horrible diseases, but malnutrition is a huge challenge in a lot of these remote communities. So yeah, help us help them.
Have you ever had RUTF, Daniel?
I've definitely given it out. I should probably try it. I should probably see what it tastes like.
Because maybe after you taste it, you won't want to give it out.
I think I would still want it because it is. People definitely, the moms, the mom show up, yeah.
All right, it's time for your questions for Daniel. You can send yours to daniel@microbe.tv. Anonymous writes, as luck would have it, the day I was scheduled to get my flu vaccine COVID booster, I had some mild sinus drip. It felt like a mild cold. I looked up the latest advice, and it was if your symptoms are mild, you should go through with the shot. So I did, but it turns out it wasn't a cold, it was COVID. So what does it mean for the effectiveness of the COVID shot? Should I have it redone? If so, when? And it was Novavax.
Okay. So, I mean, this is a pretty common scenario, right? You go, you're scheduled to get your vaccine, you've gone through all the hoops, you've got a little bit of a runny nose. Oh, it's probably rhinovirus or something. And then it turns out it's COVID. So, if you had not been vaccinated and you got COVID, we say, hey, wait 3 months before you get that shot. If you get the shot, right, you got the shot. I think you can still sort of stick with your, if you're in a high risk and it's recommended every 6 months, if it's recommended once a year, I don't think there's going to be any negative impact on the effectiveness of your COVID booster shot. So you don't need to redo it. You're good for now. And I don't think it makes a difference whether it was Novavax or not.
Simon writes, thank you for keeping the information flowing during these unprecedented times. Been listening to TWiV on and off about a year and made my first but not last donation in January. TWiV and TWiVo have become two of our favorite podcasts to listen to on the school drop-off pickup run. Now, my question, as this is headed towards becoming a great debate in our household, from an avian influenza perspective, how safe, unsafe are runny eggs? Assuming normal grocery store cage-free eggs. And what would change this news-wise, especially given the current lack of communication allowed from CDC? The standard answer that eggs are safe if cooked to 165 completely ignores the reality of an over-easy or soft poached egg. It also looks like the time temperature curve may be favorable to cooking eggs with an immersion circulator. If high-path avian influenza is a concern, how would you need to hold 145 or 150? How long would you need to hold for the eggs to be safe? Or how about 130 for that matter? Effectively do-it-yourself pasteurization. I suspect this would need hours. Please let me know if you need any more information. You can't have soft-boiled eggs anymore. You got to cook them.
It's interesting. A lot of the advice about egg safety has come from bacterial infections, right?
Yeah.
Go to the place and, little warnings if you choose to have your egg sunny side up, you're living on the edge. My mom's always eating oysters and I'm like, oh my gosh, what are you doing there? I think this is tough. Right now, we think, the eggs are safe. We haven't seen a single report of somebody getting highly pathogenic avian influenza from egg ingestion. I look forward to these kind of exciting debates in the home.
Seems to me, though, if you look at the CDC website, they have 165, which means white. You can't have soft eggs. You can't have a poached egg. You can't have an over easy. You got to cook them. Sorry.
Yeah, I mean, from a safety point of view, that would be the recommendation.
Jay writes, each spring, many classrooms, 4-H groups, etc., participate in a learning project of incubating chicken eggs in a tabletop incubator and then caring for the chicks. There are state regulations about eggs needing to have a Pulorum clean certificate and or a national poultry involvement plan. Even so, I'm wondering if doing educational egg incubation projects this spring is being formally recommended against by any group due to avian influenza. If there have yet to be any formal recommendations, what do you think is the best way to proceed?
Jay, in times like this, it's kind of tough, right? Because who's gonna let us know? Who's gonna give those recommendations? I just talked to the MMWR just came out. We were waiting for these 3 reports on avian influenza and nothing. You're gonna have to sort of do your best to keep an eye, do your best to figure out are we really going to be in an information vacuum? Because this has always been just such a wonderful activity, right? The eggs and the incubator and the kids see the eggs hatch. Really, what a wonderful learning experience. We're going to have to keep our eye on what goes on and also this issue about how much do we know what's actually really going on.
Well, the problem is that you could get chicks. And then as you're doing your experiment, the farm says, oh, we're H5 positive. So, that's the issue, right?
Yeah.
Okay. BA writes, I gather that polio data is not reported by the CDC in its wastewater surveillance reports on various pathogens. Is it possible for state or local governments to obtain and report the data from collection centers in their areas? Does the scientific community know what polio data are collected in wastewater facilities?
Vincent, I'm going to let you field this one, right? Because this is, we're not really supposed to look.
So around the time that there was the polio in upstate New York in summer 2022, right? The CDC did some wastewater surveillance in the area, including Long Island, Daniel.
Oh yeah, we had it. We had a detection out here on Long Island.
Yeah, but no, it's not possible for state or local governments to look for it. They're not allowed to do that, and consequently, the scientific community doesn't know what polio data is collected.
Yeah, so tough, because it's nice to know.
Caitlin writes, listening to your discussions and Dr. Griffin's updates from his car and stairwell of the hospital got me through 2020 and beyond as a hospital nurse. I'll always be grateful for this podcast. I'm now 30 weeks pregnant, due mid-April. When I was just over 11 weeks on October 1, I got both flu and Novavax. For reference, I previously received 5 COVID mRNA shots every fall, and the initial 2 doses in late 2020, early 2021. I asked my OB about getting an additional COVID shot since I've entered into the last third of pregnancy, like how I'll now get Tdap. They literally said, well, you're fine. Infants actually handle COVID pretty well. It's the RSV you have to worry about. I didn't appreciate this answer for a few reasons I don't think I need to explain. So now I'm here. Does the question I posed have any updated guidance? Aware I'll give birth in the spring, when the overall respiratory virus season will likely be common. Do you know of any updated evidence on whether mRNA or protein-based shots are worth it to provide benefit to baby or mom in this timeline?
Yeah, so Caitlin, sorry about the answer you got. But yeah, so we do have information. And, children during the first 6 months of life, their chance of being hospitalized with COVID is up there percentage-wise to the, people who are 65 and over, right? They're coming into this world COVID naive. Now, if you get a COVID vaccine during that last trimester, and we've actually looked at the study, sort of the beginning of that last trimester is probably ideal to give a chance for the maturation and the antibody levels and everything to transfer. That's the ideal recommended time. So beginning of third trimester to protect the baby.
It's TWiV Weekly Clinical Update with Dr. Daniel Griffin. Thank you, Daniel.
Oh, thank you, and everyone be safe.